Hello, I'm Cornell Clayton. I'm the director of the Thomas S. Foley Institute at WSU. And on behalf of the Institute, I want to welcome you out to our event today. We've put together another exciting schedule of speakers for this semester. And that includes a distinguished lecture series, which will begin next week on the crisis in American constitutional democracy. The first lecture in that series will be delivered by the renowned American historian from Columbia University, Eric Foner. That's next Tuesday, February 16th at noon. So please put that on your calendars. I want to thank the College of Arts and Sciences for their continued support of the Foley Institute and its programs. You can learn more about our upcoming events and all of our programs at the Foley Institute by subscribing to our YouTube station, liking us on Facebook, and or emailing us at tsfoley, as in Tom S. Foley, at wsu.edu. And we will put you on our mailing list to get information about our events and programs. So perhaps nothing in recent history has been so disruptive to the lives of Americans and to the world's economy as the COVID-19 pandemic. Unlike most other countries, responsibility for managing the response to this public health crisis in the United States has fallen almost entirely on state and local level governments. This has cast new light on the importance of these governments and generated numerous political controversies surrounding the actions taken by local public health agencies and their officials. These have included controversies around restrictions placed on travel, businesses, and social gatherings, the efforts to test and trace the spread of the virus, and now on the efforts to roll out vaccines. To help us understand how Washington state and local health agencies in Eastern Washington have responded to the pandemic, we have with us today two people who are very knowledgeable about both the medical and political aspects of the pandemic policies. Dr. Bob Lutz is currently a member of the Washington State Department of Health's COVID-19 response team, serving as a medical advisor. Dr. Lutz received his MD from Temple University and a master's degree in public health from the University of Arizona, where he also pursued a fellowship in integrative medicine. After working in urgent care for several years, Bob became the clinical director of urgent care for Rockwood Clinic in Spokane. And from 2017 until last year, he served as the top public health officer for the Spokane Regional Health District. Amber Lenhart, our other guest today, recently served as a health policy specialist at the Spokane Regional Health District. She has a master's degree in public health from the University of Washington and over 10 years of public health experience at both the local and national level. Amber is an advocate for systemic change through community-driven policy and is the co-owner of Cedar Plank, a company focusing on improving the quality of life for people in the inland Northwest. Dr. Lutz and Ms. Lenhart are going to speak for about 30 or 40 minutes, after which we'll have some time for discussion. If you have questions, I encourage you to send those to me at tsfoley, again, Tom S. Foley, tsfoley at wsu.edu. So Bob and Amber, I'm going to turn the time over to you now, and I will be back later with some questions from our audience.
Well, thank you, Cornell, and good afternoon, everyone. Yeah, as Cornell said, Bob Lutz, and what I'd like to talk with you today about is sort of one of the last phases, hopefully, of the COVID-19 response, really around vaccinations. And it's obviously, as Cornell mentioned, a public health effort that is just incredible in its logistical challenges and not unlike any other aspects of the approach to public health and the response to the COVID-19 also has become, unfortunately, somewhat political. I just want to back around a little bit. This, just to kind of give you a sense of where we are right now with COVID-19 across the state. This is a modeling slide that shows, and you're probably all familiar with the term called R0. This is the estimate R0, and as you can see, we are below that 1.0 level, which is sort of the goal. I really emphasize the fact that we need to keep this estimate down low. You've all heard of the variants that are out there. We know those variants, at least one of the variants is here in Washington state. And so given the fact that they're more transmissible, the focus really is trying to keep the prevalence of COVID-19 as low as possible when, not if, but when those variants hit our local areas. This again is a modeling slide showing that, as you can see from that winter surge of November and December, our cases in all age groups have dropped significantly. And this is what's called an epidemiological curve, which again reflects the fact that winter surge is definitely seeing a very nice overall decrease. So that's where we are right now with the COVID-19 cases in the state. If you're not familiar with this website, the Coronavirus Vaccine Tracker of the New York Times, it's definitely the site to go to find out the latest information on vaccines, where they are in their research, and when they're going to be approved, if at all. And I just referenced these three, the two that you're familiar with, the mRNA viruses, and then, as many of you know, J&J, Johnson & Johnson, just submitted their EUA, emergency use authorization request, to the FDA. That should be, the study should be done on February 26th, I understand, and we'll look a little bit at this vaccine as well. And I just referenced this slide. There are three major types of vaccines that are looked at for COVID-19. We're going to focus on number 2 and number 3. Again, the mRNA virus, the Pfizer and the Mrna virus, and then vaccine, and then, as I mentioned, the J&J, which is the number 2. So mRNA viruses, I should say mRNA vaccines, kind of cool technology. It's been around for quite some time, and yet this is the first time that we've had vaccines up and running using this very interesting technology. mRNA is part of your cells. And what's interesting about this is that it takes mRNA and it allows the mRNA within our own cells to create proteins. And so the vaccine essentially tricks your cells into creating specific proteins from the SARS-CoV-2 virus. So in a sense, your cells are making the vaccine. The important portion is, however, that not the entire virus is made, but rather just the spike protein. And as you've learned by now, the spike protein is what the virus uses to get into the cells. So the vaccine stimulates your immune system to make cells, make proteins that recognize and destroy this spike protein. And that's how individuals are protected from getting COVID-19. So that's number 3. The other vaccine, as I mentioned, J&J, it uses a different technology. It's called an adenovirus. And adenoviruses, those are your common cold viruses. There's hundreds of them. There's maybe 50 plus that cause our colds. Well, what we do with this is that we essentially inject the genetic material from the virus into the adenovirus. And so essentially we're using one virus to get the genetic material of the other virus into your body. In the same way, again, here we are, we're jabbing, you get your vaccine, and then the mRNA causes the body to produce the spike proteins and stimulate the immune system. And it's kind of like a Trojan horse. Imagine that you've now used this adenovirus to get proteins into your body to then create the immune system so that, again, you fight off the infection. So really, very interesting technology. And this, again, I think has been really key. You know, if you look at the typical timeline for vaccine technology, we're talking oftentimes in decades, a decade plus. We're talking here the fact that this has been out there in less than a year. So really just incredible technology. So, okay, we have these vaccines. Okay, how do we determine who gets them first? Well, a couple of different organizations, what's called ACIP, which is from the CDC, the Advisory Committee on Immunization Practices, they came out with their guidance. And you've probably all sort of seen these different terms, 1A, 1B, 1C, 2. This is what ACIP recommended for distribution of a somewhat very limited resource. And then the National Academies of Medicine came out with this guidance. But again, I emphasize that these were only guidance documents. They were allowed, therefore, to be used by states, by departments of health, and governors to figure out how those states wanted to prioritize their distribution. And the reason why both groups recommended first focusing on healthcare workers who are high at risk, and then also individuals living in long-term care facilities, is that you can see from the following slides that I'll share with you, by far and away, disproportionately, the individuals who end up being hospitalized are oftentimes seniors, especially seniors living in these very, very fragile environments of long-term care facilities. So you also see that there is a direct association between the number of medical conditions that you have and the likelihood of being hospitalized. And then, as we know, the older you are, the greater the likelihood. And then, unfortunately, the older you are, the more you have, the more medical problems you have. And especially if you find yourselves in long-term care facilities, as you can see, the disproportionality, 6% of cases, and again, these are back to November data, but 40% of the deaths. So that's why both organizations really prioritize this very fragile population as essential to get vaccinated soon. I also point out this fact, and Amber will speak a little bit more to this following me, but there is a significant disproportionality of COVID-19 infections, hospitalizations, and deaths in our marginalized populations, our Black, Indigenous, and people of color populations. In Washington State, you're looking at our Native Hawaiian and Pacific Islander populations significantly at greater risk of COVID-19 and its complications. This is similar to in Hispanic populations and our African American populations, as well as our American Indian and Alaska Native populations. And the disproportionality, unfortunately, has oftentimes occurred because of the fact that these populations have historically not had great access to medical care, if at all. They may have other medical conditions, and where they found themselves, i.e., they found themselves as essential workers. They're out in front. They didn't have the luxury of doing Zoom meetings and doing work from remote. They were oftentimes essential workers, really doing the work that needed to keep our society moving forward. So there's a real focus on equity when it comes to ensuring that people get vaccinated going forward. And within Department of Health, again, equity being a priority, these are the different 7, if you will, areas that the state has really prioritized. Access barriers to health care, higher risk for exposure, again, those individuals who really are essential to the health and well-being of populations, areas where you have higher risk of spread, the populations that I just mentioned to you, the comorbidities, the medical conditions that I mentioned, and again, those who are very high risk for actually spreading COVID-19. So what Washington State did was we created our own sort of phased approach. And right now we are in, depending upon where we are, we're probably in about phase 1B for some areas. But again, what we're seeing across the state is that some communities are able to move a little faster just because of their populations. But again, phases 1A, where you're focusing on those high-risk health workers, and then other individuals who are at risk. And then you're looking at phase 1B and the different tiers. Really important in trying to figure out how many people actually constitute these different tiers. And this is just a guesstimate, but you can sort of see that based upon the data that were available at Department of Health, these were the different populations. And so you're looking at almost 400,000 individuals who work in high-risk settings, healthcare workers, first responders, almost 200,000 individuals who live in long-term care facilities, and then more than 1 million people over the age of 65. Those were the priorities given. And then you look at other risk factors such as other medical conditions and things. So these are, again, some of the data that were used to identify how to stratify vaccine distribution across Washington State. And this is just another example of, again, the same kind of information, just a little bit more granular. And so you've maybe seen this graphic. This tries to provide people information on where they fit into the different tiered system. And so you have right now in, B1, we're still sort of in that area right now, but certainly soon, depending upon where you find yourself, you'll be getting, again, more people vaccinated. The hope is that and I know this is not necessarily encouraging, and I'll talk about it in a little bit, but we're hoping that within months, probably by mid-June, maybe early July, enough people will have been vaccinated that anybody who wants to get vaccinated will be able to. And again, so much of that is really predicated on having available vaccine. So we're all dealing with the challenges. This is, as Cornell said, just been an incredible logistical challenge. Imagine, if you will, that you have hundreds of millions of people across the country demanding vaccination. You have very limited resource. And so it really does come down to basic economics, supply and demand. So how do you move a very limited resource based upon the demand? As I mentioned, logistical challenges have been immense. You've heard of these mass vaccination sites. They are not done by just a couple people, but oftentimes by a couple of hundred people, maybe people that you see on the ground, but then all the people behind the scenes actually making them happen. How do you get the word out? How do you get the word out and really engage people to know that the vaccine is safe? And again, we have, unfortunately, throughout this pandemic, really seen that misinformation in so many ways has really challenged our efforts at the public health level. Just with respect to vaccines, different data systems, communication, and then capacity. We are really stretching the public health system and the healthcare systems immensely. Healthcare systems have been thankfully not overwhelmed because of the fact that we've done a good job, but nonetheless, when you have work that's been going on for over a year, public health and healthcare systems really find themselves taxed. This has been a long road to move. And again, the challenges continue to stay in front of us. And then, as I mentioned earlier, and as Amber will speak to, how do we really reach those communities where disproportionately COVID-19 has impacted them? Just a little graphic to demonstrate sort of where we are. You see that we're still sort of in that light blue section to the left, constrained supply, and yet we really need to really prioritize certain populations, pent up demand. And how do we explain to people that we've prioritized certain populations based upon risk factors, based upon how the government, Department of Health, and the governor have prioritized individuals? Hopefully, as I said, as things open up, we'll get more vaccines available to people. And this is just a slide. Again, it's kind of busy, bear with me, but on the far left, you can see the estimates on number of individuals eligible for vaccine. You therefore see sort of on a timeline what we're looking at getting all the way through phases 2 and phases 3 and 4, probably sometime by mid-July. And again, this is all looking at these 2-dose vaccines. When J&J, and I have no doubt that the J&J vaccine, Johnson & Johnson vaccine, will get their EUA, that will be a bit of a game changer, and it'll be interesting to see how this timeline is adjusted accordingly. So this is where we find ourselves right now. This photograph taken back in January shows a long queue to get vaccine. And this is what we sometimes see. This is unfortunate, but this is our reality right now based upon a very limited resource. And just doing the math, the governor has wanted to have at least 45,000 doses per day. And if that is given 2 doses, you're looking at 70%, estimated 70% of eligible population, which is what is guesstimated to be the percentage of the population for community, otherwise known as herd immunity. You can sort of see that if we stick with that timeline, that's 190 days, that's over 6 months. That's going to put us into August and September. And so how do we speed this process up? One of the ways is we look at how do we get it done? So traditional delivery systems, healthcare organizations, pharmacies, workplace clinics, those are queuing up, and hopefully we'll see some of those in the near future. Also, just really trying to enhance existing delivery systems. So that's where your local public health organizations, working with community vaccination sites, getting vaccine out to populations where they are, not expecting people to come to you to get vaccinated, and then pop-up clinics. And then as we're seeing, as I mentioned, in some areas like in Spokane, like in Clark County, like in Seattle, King County, and Snohomish County, these drive-through mass vaccination sites and mobile vaccination teams as well that are supported by the state and by the National Guard at this point. I mentioned challenges. And again, I think these are some of the challenges that exist in front of us. So for example, need to proactively address common healthcare access barriers. People identify cost as a simple barrier to vaccine. Now, with respect to the vaccine, we know they're free, but irrespective, trying to get them into vulnerable populations will remain a challenge. 2 doses. It logistically is very challenging, and also it's sometimes very difficult for people to be available for that second vaccine, depending on whether it's Moderna or Pfizer, 21 days, 28 days. Where am I going to be in 21 days or 28 days? Am I going to be able to go back to the same site and get vaccinated, or am I going to find myself someplace else? Am I a agricultural worker where I'm going from one place to another and I may not have access to the same facility? And then again, trying to really take vaccines to where people are so that they feel safe, that they feel familiar, and again, they're not concerned about risks if they get vaccinated. And I think this statement at the bottom really sort of says a lot, that what we're seeing, which is not surprisingly, this is what we've seen throughout the response, that unfortunately who you are and where you live and what you have access to oftentimes determines what you get. So one of the things, to the credit of Department of Health, that they did was they really reached out to different populations. They looked and did qualitative research. They really, I forget how many hundreds of people and how many sessions were held to really get a sense of, as we move through the vaccine response, how do we do it effectively? How do we do it so that our populations are, again, vaccinated effectively? And in general, with respect to vaccinations, these were some of the themes that came up. People get the fact that vaccines work for the society, but they're also concerned oftentimes about their own individual responses to the vaccine, side effects, allergies, potential long-term health impacts, and with a very strong anti-vaccine movement, whether or not vaccines are really safe. Racism, discrimination. We know that for many of our marginalized populations, this remains a significant concern. Why is it that we're prioritizing these populations for vaccination? Could it be that we're actually still doing medical trials on these vaccines? And so what we found in this sort of general work with qualitative work was that especially African American and Black adults, the Latinx populations, Asian American adults, Pacific Islander Native Hawaiian populations, and our LGBTQ adults really were concerned about discrimination and how it could potentially impact how vaccines are prioritized. Interesting that some people still believe or are concerned that vaccines can actually give you the disease, but they do recognize that, again, not all vaccines should be treated equally. So the qualitative work then was expanded to look at COVID specifically. And the interesting responses were that, not surprisingly, there is sort of a wait and see. Let's see how things, I don't want to be the first in line. I'm not going to be a first adopter. Let's see how things play out. Side effects concern. I mentioned previously historical trauma. Excuse me. Doctors, healthcare providers still remain the most trusted source of medical information, and therefore really trying to get the healthcare community strongly behind vaccination efforts. Concerning for me as a clinician when I hear that we still have significant percentages of healthcare workers who are not willing to get vaccinated at this time because they're taking that wait and see mentality. And yet we know that they really represent a population that if they get vaccinated, then others will follow suit. Who else do you trust? Unfortunately, we find that, politics, as I've mentioned, has really engendered a lot of mistrust in people. And so you can't always turn to the news. You can't always trust what you read. And so where do you find good information? They want proof. Show me that it works. And I think, as we go on with our vaccine response to the COVID pandemic, we will see more and more proof that the vaccines really do work. Thankfully, people are very, not surprisingly, very willing to end and see an end to this pandemic. And there's very much a desire to protect others, to protect both family, friends, and others, because as we've seen, you go back to masks, where we talked about masks being helping others protect others. People want to really, they have a societal good that they see by getting vaccinated. Let's be honest, the term warp speed, Operation Warp Speed, bad choice of words. And yet I would argue that in spite of all the political rhetoric around it, it really has been amazing that we've had these two very, very impressive vaccines up and available, albeit not both went through warp speed. But the J&J vaccine was a recipient of funding. Irrespective, you see, again, really great benefits from that process. And then just two other issues around moral obligation. People feel it's really important to get vaccinated because, again, they feel sort of a moral responsibility for doing so. And what's going to work is just being honest, transparency, just really providing people information on what's needed and being honest and accurate. So like every other vaccine, there are side effects, but I think it's important for people to realize that this is being monitored. This is being monitored both by what's called VAERS, which is the Vaccine Adverse Event Reporting System through the CDC. And we also have a couple of different means by which we can monitor side effects. There's something called vSafe, which is an app which you can get on your phones, and it's active surveillance. So after you get vaccinated, you can provide information on a daily basis, and then the farther you get out from the vaccine, it checks in less and less frequently. I mentioned VAERS, and then also CDC is actually doing individual case consults. So you have a concern, you call the CDC, and you can actually talk with a representative there to provide your concerns and ask your questions. This is just a little bit of a busy slide, but this just demonstrates to you the multiple means by which we are monitoring for side effects. And do side effects occur? Yes. Have there been deaths associated with it? Unfortunately, yes. But again, when I looked at the numbers the other day, you're looking at rates of, I want to say 4 per 1 million doses for, generally speaking, the two vaccines that are available. So again, that's actually less than what we're seeing with other vaccines. So in spite of the fact that they are up and running within a year, these are very, very safe vaccines. Side effects do occur. I'm in conversations with colleagues on a daily basis and just hearing about the sore arms, but certainly after vaccine 2, some people have a flu-like illness. That's again, you look at the opposite, potentially getting COVID-19 and having to be hospitalized, or unfortunately even having more serious side effects. I'll take a 12-hour period of feeling feverish and hanging out in bed. And I'm just going to show a couple of resources. This is just on our website at Department of Health. This kind of gives folks an idea of where we are. When I took this the other day, we had a little bit over 800,000 doses given. We will reach the 1 million mark this week, which is very exciting. And these are all, again, just some other resources where you can find information about vaccination, questions. And I will end it with that. Thank you. Turn it over to Amber.
Thank you, Dr. Lutz, and thank you everyone who's helped with the technology today. I hope you can see my slides as I try to get it into presentation mode here. Oh dear. Well, as I wait for my computer to work, I'll introduce myself again. I am Amber Lenhart. I am going to talk a bit about equity some more. Bob talked about equity in the planning and the distribution of the vaccine, and I want to talk more about how equity shows up in the uptake of the vaccine, and how do we make sure that our vaccines are getting to the right people. One lens that I'm going to offer is how we can develop better policies and campaigns by looking to behavior change theory, as well as looking very locally at our local community and understanding their needs. And I'll provide some specific examples from Spokane of how we've, the Spokane area of what we've been doing. So Bob mentioned some of our problems with getting enough vaccines in the first place. But if we only had enough vaccines, we could just get everyone vaccinated and get back to eating in restaurants together, right? Well, we know it's way more complicated than that. And Dr. Lutz shared some of the themes that had come out of the State Department of Health's research in what goes into people's decisions about whether to get vaccinated or not. So I'll walk through some of those. Part of whether or not I want to get vaccinated is, do I even know how? Do I know where to go? When to get vaccinated? Which phase I'm in? Is it something that I'm even thinking about? Do I think it's important? Or do I think COVID is serious and scary? Or do I think COVID is fake? Can I get there? Is there anything in my way? Physical barriers? Do I have to drive to a mass vaccination site? Do I need to know how to read or speak a certain language? And then do I even want to get it anyway? How do I feel about this vaccine? There's a lot of factors that play into people's intentions. Things like, how do I feel about vaccines in general? Did I get my measles vaccine or did I opt out? Did I have a bad vaccine reaction in the past or know somebody who did, or know somebody who's had really bad COVID? And so I'm really eager to get this vaccine. And do I think it's going to be scary and painful? Or am I pretty confident it's just going to be over really fast? It'll be easy. Social norms play a large role in people's decisions about vaccines. So do I feel pressured by society or pressured by my peers? What are other people like me doing? Do I think that my peers are getting vaccinated, or are they waiting and seeing, or are they scared? All these things are points that we need to try to address when we're trying to implement an equitable vaccine rollout. So there's no one size fits all campaign or program or policy, depending on which of these factors is really influencing someone's choice about vaccines. So it's helpful to look at some local examples here. So do people know how and where to get the vaccine? I would ask you, watchers, do you know how and where you'll get the vaccine? How did you find out? How do you know? Did you look it up online? Did you go through the phase finder? What if you didn't have access to the internet? Or if you didn't read English? Or what if you didn't have a regular doctor, like that quote that Dr. Lutz shared? So in Spokane, we are making efforts to try to make sure that things are in languages that are accessible to different audiences. And there are other attempts to get vaccines out to people who might otherwise face some of these barriers about knowing how and where to get the vaccine, like homeless outreach and some of the other types of pop-up clinics that Dr. Bob talked about. And is getting vaccinated on my mind? Do I think it would be an important thing to do? We do have people, I can tell you, who think that COVID is not real. And so they might not be thinking that it's a very important thing to do, to go get vaccinated. I think there might also be folks out there who just, if you're not getting your basic daily needs met, you don't have a roof over your head or food to eat, that getting a vaccine might not be the most forefront thing on your mind. So we're trying to make sure that there's lots of messaging out there to keep people thinking about getting the vaccine. And can I get there, or are there barriers? So how would you get there? Are you going to drive, walk, take a Lime scooter? What if you didn't have access to any transportation? And then how would you get there? Or if you couldn't leave your kids at home? Or what if you don't feel safe there? One thing that we've heard in Spokane is that the mass vaccination clinic is operated by the National Guard. And so it does have a very military feel. And for some of our Black, Indigenous, and other people of color in our community, that militaristic style is not very comforting to people. So we're trying to think about ways to address those barriers and bring the clinics and the vaccines to places where people are used to going. Maybe places where they go to pick up food pickups, or access services, unemployment services, or community clinics where they see people who look like them and people who they recognize and feel comfortable with. And then do I even want to get the vaccine? This is where social norms come in and trusted messengers. What are other people like me doing? And are my questions, do I feel like my questions are getting answered? What we've heard in the Spokane area is that there are some concerns about a lack of education and awareness among certain populations, that certain folks know a lot about the vaccine, but that other groups have been left out of these conversations, or materials just haven't been created for them. There are there's concerns that we're also making a lot of assumptions about the reasons that people might choose to not get vaccinated, that they might that we need to give people a trusted platform to go and talk about their questions and their concerns and have them answered by trusted messengers. So we've been working with the NAACP Healthcare Committee locally in the Spokane area to bring our NAACP leaders to answer people's questions and to be in some of our materials, campaign materials, to get people to go and get their vaccines. And with that, I am going to go ahead and leave it there and stop talking and open it up for any questions I think that will come our way. So thank you so much for the time.
All right, great, thanks. Dr. Lutz, you going to come back on and join us? Great, okay. So
technology, Cornell, my apologies.
I know, it gets us, all of us. We have lots of questions. I'm going to begin with one by Griffin Grubb, who's a student here at WSU. He asks whether or not the change in presidential administrations from the Trump administration to the Biden administration and their approach to the pandemic has impacted Washington.
Boy, that sure is a loaded question. I appreciate that. Thank you, Cornell. I would rhetorically ask, what was the approach from the previous administration to the pandemic? Essentially, it was left to every state. You know, I think what we're already seeing from President Biden is a much more national approach with guidance and actually listening to science. And so what I am very pleased to say is that we are definitely seeing information to suggest ramping up vaccine availability, things that he's putting in place to not only improve vaccination efforts, but also to really try to get the pandemic behind us. So yeah, long story short, I'm really pleased by the changes we've seen in only a very short period of time.
Okay, great. Lori Barreto asks a question about schools and the vaccination of teachers. Do you think that with the opening of schools, we're going to see the infection rate increase again? And what do you think about the CDC's preliminary findings that teachers don't need to be vaccinated in order to open up the schools?
Yeah, I think that, you know, right now, for example, across Washington state, about 90% of students are in some degree of in-person instruction. And again, we can speak to what we have seen up in Spokane County, what I see. I'm also the health officer in Asotin County. And what we have seen both at the state level, local level, and national level is that disease transmission in schools, when you put the mitigating efforts in place, the physical distancing and the masks, it really makes a huge impact on transmission in schools. It's what happens out of schools where you have problems, what kids are doing, what teachers are doing on their own. The important thing to realize, however, is that the data have shown that infections in schools don't necessarily translate to increasing disease in the community. It's the opposite direction. So it really becomes beholden upon us to decrease transmission and disease in the community, to prevent transmission in schools. Again, I think that teachers, as we have prioritized in Washington State, they're in one of the tiers because they are considered essential workers. But the CDC still recommends that they get vaccinated. They're just not going to be prioritized the way healthcare workers would be.
Okay, great. Amber, I think I have a question for you. We have a question from Connor Simmons, and he asked specifically what types of ways that public health officials can reach out to skeptical communities.
I think the work from the Spokane NAACP Healthcare Committee is a great example of how public health officials can work with groups that are pre-existing in the community, that are trusted messengers, to access populations that might otherwise be harder to reach, or with whom the health officials don't necessarily have a deep, long relationship built on trust. You can work with your local urban Indian health program or tribal partners. Find your local NAACP branch. Do you have a Asian and Pacific Islander coalition, perhaps, that you can work with? Finding these trusted allies and bringing them into the work, hearing their questions, and then, like Bob said, having that transparent message about what's going on, I think is some really concrete things that public health officials can do to help.
Interesting. I'm curious, I was looking at that data that Bob showed, why the Asian Pacific Islander community is so much more impacted, even in other, marginal communities.
Amber, do you want to speak?
Yeah,
Amber?
Bob, I know Bob worked a lot with some of our Marshallese populations when he was at the health district, so I definitely want to hear what Dr. Lutz has to say too. But we know certain things about our Pacific Islander community in the Spokane area. We have a large Marshallese population, and there are cultural norms for our Marshallese neighbors that put them at a higher risk of contracting and spreading COVID. We know that our Marshallese population, they travel. If somebody's having a wedding or a baby's having a birthday, you travel regardless of whether there's a COVID outbreak going on. So we also, like Bob said, had a lot of folks from this population who work as essential workers or work in the manufacturing type of jobs where they were not able to work from home and maybe even worked 2 jobs. And so if you had one employer who found out that you had COVID, but you could still go to your other job and get your paycheck, then people might have been pushed to do that just so that they could meet their other needs. So I think that's part of why we saw some of that in the Marshallese community and Pacific Islander community, along with just lack of trust, lack of communication in the right language. We've had people go to the emergency room and leave not even knowing they had COVID because the providers there didn't speak their language. So there's a lot of cultural barriers in our way to make sure that this is rolled out equitably. But Dr. Lutz, do you have any other experience from your work with the Marshallese population or others that I missed?
Amber, I think you hit on a lot of them. I think I would just bring up one other piece. You look at the populations, and it's not any different for some other populations where, again, multi-generational families are the norm. And so you look at oftentimes having families where you'll have grandparents taking care of grandchildren. And you have, again, in a lot of these populations, it's not only biological families, but families by kinship. And so when our Pacific Island populations come to a community, it has been historically difficult for them to find homes. And so they'll oftentimes start spending time with other family members. And a family member brings COVID-19 into a family. As Amber mentioned, they're very close-knit. And thus you see a rapid transmission of COVID across all kinds of family boundaries. So disproportionately, our Native Hawaiian, other Pacific Islander populations in Washington state have really been impacted. We have a large population in Spokane, but also in the Everett and Seattle areas, as well as in the Vancouver areas, also populations that have been impacted.
Okay. So Ali Figlin asks whether or not the Washington state's policies on vaccinations differ in significant ways from other states, and how so?
Not necessarily. I mean, I think that, as I mentioned earlier, Cornell, the federal government, both through ACIP as well as through the National Academies of Medicine, provided a framework. They looked at the data and they provided a framework on how every state could prioritize their individual constituents. We know, for example, in Florida, the governor decided to provide vaccination to everyone over the age of 65. That was his choice based upon his demographics. I think Washington state, we've definitely used that guidance as a framework. And then you look at just the huge numbers. I think one of the things that we've looked at very critically is how can we get vaccinations into a majority of individuals who are either at risk, or where do we get the most benefit with a very limited resource? And that's how the prioritization has taken place. It's a little bit different in Oregon. It's a little different in California. And again, I think it speaks to one of the initial questions that you asked me, Cornell. The national approach has been lacking. And I don't know if, in hindsight, if President Biden had been in before vaccines were rolled out, whether there would be a more consistent approach from state to state.
Okay, Stasha Moon asks a question, asks whether you can speak to the lack of animal testing of these vaccines. They were developed so quickly, and whether or not that means we can have less confidence and trust in them and not knowing how animals responded and going straight to humans.
Yeah, that's one of those unfortunate pieces of misinformation. There was animal testing in the vaccines. So every vaccine, irrespective of the fact that these came to market faster, they have animal testing. So animal testing was done. But again, part of the misinformation out there is that no animal testing was done. But I can tell you that animal testing was done. And that's how they were able to move into the very first phases of phase 1 trials.
Okay. I have another question from one of our audience members, and it's about higher transmission rates in our surrounding states. How does that impact Washington?
Yeah, that has been a challenge, Cornell, especially for counties along the eastern border of Washington state. You know, we've commented that COVID-19 does not know geographical barriers, and COVID-19 is exquisitely behavior sensitive. So if an individual, irrespective of where she or he lives, decides to follow unhealthy behaviors for COVID-19, i.e., not wearing face coverings, gathering in groups, then that is a risk factor. We know in Eastern Washington that has been challenging for us. And unfortunately, many of the dynamics that we see just a couple miles away across the border have therefore affected us. So in Spokane, what we saw in Coeur d'Alene is what we saw in Spokane. What I see in Lewiston is what I see in Clarkston. And what I see in Moscow is what I see in Pullman. It's the same dynamics. It doesn't know a geographic barrier. It follows behaviors.
Okay. So I have a question I want to ask. This is a personal question. It says we're in the process of putting together our fall teaching schedules at WSU. Are we going to be back in person, do you think?
Let me look into my crystal ball. You can see how clear it is. No, I mean, honestly, Cornell, I think there will be some degree of in-person instruction. I really do believe that. As I mentioned earlier, I think the projections are right now that by mid-July, hopefully earlier, if we get more vaccines, you know, that's 70% of the Washington population will be vaccinated, and that will give us some degree of herd immunity, community immunity. I think that said, there are a couple of things that are out there that we have to be cautious about. very concerned about the variants, very concerned about the B117 variant, the other variants, B1351 and the P1, because they have increased transmissibility. And there is some evidence that they may not be as responsive to vaccines. And so already the manufacturers are looking at how they can make some minor changes to the vaccines to make them more responsive to these variants. But I do believe we will see in-person instruction, but we may not have classes. You may not have your large classes of 100 students in a classroom. It may be pared back down somewhat.
Yeah. What does this really mean in terms of these mutations we're already seeing and it will continue to mutate? Are we likely to have this virus with us for years going forward, like the flu virus? Are we going to see a variant of this every year coming back?
Yeah, I think, Cornell, you look at this as what's called a coronavirus. We know that currently there are 4 what are called endemic coronaviruses, meaning that they occur in all environments. They're with us year round. So there are 4 coronaviruses that circulate on a yearly basis. You get a cold from one of the coronaviruses, and you have a short life of immunity, maybe a year or 2, depending on the virus, sometimes longer or shorter, and then you can get that cold again. COVID-19 will be with us. Early on in the pandemic, there was an epidemiologist who said we will probably start looking upon this as the cold, flu, and COVID-19 season going forward. Viruses mutate. They do it based upon environmental stress as well as just that's their nature. And so I think what we will see, what we will continue to see is as these viruses evolve, are we going to see strains that because of environmental stress, meaning that it's environmentally stressful for a virus if nobody can contract it. So how do I become more transmissible as a virus? Well, I mutate. And then I am more successful at being transmitted. So I do believe we will see viral transmission, viral evolution, and we will continue to have COVID-19 with us indefinitely. Hopefully, we'll be able to control it to the point where it may be that we end up getting vaccinated for COVID-19 on a yearly basis or with boosters, as we do with flu or other vaccines.
Yeah, I was afraid you were going to say that.
Sorry.
So Alex Hammond, who's one of our faculty members down here at WSU, asks a question about the public health official in regional health districts in the state of Washington and some of the politics surrounding them, which you know firsthand. And he asked whether you'd speak to what you see as the current strengths and weaknesses of these positions as they're currently structured and whether or not some reform is necessary.
And obviously, Alex, I am somewhat biased, and so I will tread somewhat lightly, but I think, what befell me, what befell more than 200 of my colleagues across the country have just really demonstrated how public health has been politicized. And we need to get politics out of public health, clear and simple. And I think Amber can also speak to this really well, but from my standpoint, Alex, you cannot I've always argued that public health is by definition political. It does not need to be politicized. And that's what the pandemic has showed us, that it has been politicized to the point where public health officials who are doing the best they can with the research and information and resources they have end up not, if you will, doing well from a political standpoint. Amber, your comments?
Sure, thank you. Yes, I'd love to add to this. I think that I definitely agree with what Dr. Lutz said, and I think what we've seen is that when the system works is when everyone is making decisions based on facts and research and evidence. And when it doesn't work is when people are making decisions based on politics and re-election and economics, perhaps. And so we're not the only ones who feel this way, Dr. Lutz and I. There's a group of folks in the Spokane area who are trying to change some state legislation around how boards of health are comprised, how health officers are protected or not, by the state board of health or their local boards of health. But in general, yes, I would love to see more people with public health expertise, more people with lived experience on boards of health and making decisions that affect health officers than politicians.
Alex, check out House Bill 1152.
Okay, I think we have time for one last question. You've both made clear that even with the vaccines being rolled out, we're going to continue to have to do some social distancing and mask wearing for the foreseeable future. And the question is, there's a lot of people who have been resistant to these types of measures. Have you found there's been some way to overcome that resistance that's worked in terms of convincing people that masks are a good thing and it's not that bad to wear them? Or is it just we're going to have to trudge through this?
I'll take a first stab at that one and let you wrap it up, Dr. Lutz. When I was at the health district, we did get to do a big survey of community members to try to understand how they feel about wearing masks and identify the factors that influence their masking behavior, just like the model that I showed for vaccine behavior. And just like with vaccines, there's all kinds of reasons that someone might choose to not wear a mask. And so all we can do is try to address each of those factors. If it's cost, let's give them free masks. If it's misinformation that they are fearful about the health effects of wearing a mask or the oxygen flow, then we try to explain that using very simple language and accessible science. If they're straight up deniers that COVID does not exist, we need to think about where we put our resources for the best change. And if we're talking about people who are contemplating wearing a mask, maybe just they don't know, or they don't know where to get one or when to wear one, or sometimes they forget, we can influence their behavior through messaging and campaigns. But those people who are not willing to change, not willing to wear a mask, not willing to accept that COVID is real, I think our resources are better used elsewhere. Would be my response.
Yeah, I guess the only thing I would say, Amber, is that, again, I think unfortunately when something such as simple mask wearing has been politicized, it just unfortunately has demonstrated the challenges we've had in public health. I truly hope that going forward that the lessons learned will be lessons not forgotten, and that what we have gained from the good and the bad of this pandemic really influences our practices and behaviors in the future around public health and healthcare in general.
All right, well, thanks very much. I think our time's up. Let me remind our audience of our upcoming events. Our next event is going to be this Thursday at noon. We have Margaret O'Mara from the University of Washington, who's written extensively about regulation of the internet. She'll be talking about free speech and social media, and in particular the efforts to reform Section 230. So that's again Thursday at noon. And then our distinguished lecture series on the crisis in constitutional democracy in the United States begins next Tuesday. And that's again at noon. And that lecture will be by Eric Foner from Columbia University. He'll be putting the crisis in a historical context. So put both those events on your calendars. Let me now thank Dr. Bob Lutz and Amber Lenhart for really an informative conversation today. Something I think we all need to know more about is the COVID crisis and how we're responding to that politically, and some of the information we need to know and some of the misinformation we need to have corrected. So I appreciate them today. I hope to see all of you next week. Thanks again.